we all have seen the peak coming, and at least in France and in the Netherlands, we see that it's past it. In England, probably very close to it. So the UK is a little bit behind us, it looks. What we also saw, if you go look at the slides of Dr. Brink, she'd been showing, I think it was the third slide, the hospital admission rate in the Netherlands. And what you saw there is a massive difference between areas. That was something that was reflected also in the talk from Dr. Bull. And if you know the situation in France, it's very similar there. So we have areas that are extremely affected and other areas that are much less affected. We also see that all of the three departments have used dedicated scanners for the CT of COVID patients. The indication was slightly different, but CT was a very important factor in the diagnosis of these patients. In some areas, it was used for a triage situation, like in France. In Bournemouth, it was mainly used as a problem-solving tool. We all see more and more thromboembolic disease, probably a combination of real thrombi, because these patients are extremely thrombogenic, with thrombi almost everywhere, but also probably local thrombosis within the lung. There's a very interesting area of research where we understand not enough. We've heard about the presentation of COVID with acute abdomen. That is something that I think all of us can actually only affirm. So we see that as one of the typical presentations that we have to be always alert to look at the lungs in these specific patients. There is some discrepancy on whether you need to do preoperative CT. We saw our surgeons push that in the country quite a bit. We have an ongoing study in the Netherlands. But what we see, it depends very much on the prevalence of the population. So during the high acute phase of the disease, it's probably a very good idea. But as the disease peters out, this is probably less helpful, as we've heard in Bournemouth. In Nijmegen, for example, we have decided to use only PCR testing and not a CT for that specific indication. What we have not really touched upon is what is done with people with mild disease, whether they are sent to CT or not. We're not doing it, but I have the feeling that Strasbourg is doing that. So I would like to ask Professor Roy or Hannah to maybe comment on that. Do you scan patients with mild COVID symptoms at your place?
So in the initial phase, yes, because all the patients were referred to the hospital, mild or moderate or severe disease. But during the peak, only moderate or severe disease were referred to the hospital. So in the initial phase, yes, we were scanning almost everyone. But then afterwards, we were scanning only like patients with significant clinical presentation. And now we are scanning also only patients with significant clinical presentation. Yes.
Okay. I think it's very interesting. It very much parallels the experiences that we have. We're now focusing mainly on the moderate and severe symptoms, but we also see that the percentage of actual positive scans is going down. So the CORAD system that Monique Brick was showing actually worked really, really well in the acute phase. It still works, but we see more and more of CORAD 3 coming up. So basically unusual presentations. There are still the occasional 4s and 5s that are very likely to be COVID, but we see that these become more rare as the disease is slowly leaving the background in the general population. I think that's very interesting for the future is the fact that we in the hospitals are only the ones that can basically do whatever we can. And it means that if we are overwhelmed by the disease, we lose it. So it's our population that wins or loses the battle against COVID. And we have seen that the social distancing measures actually work. And it takes about 2 weeks till we see that the numbers go down, and about 3 weeks till the ICU admissions and the deaths go down. So there's a substantial lag time. And if you look at the politics around COVID, we see something that was very similar in all European countries. While COVID was still in China, we said, we're Europe, it doesn't play here. When it was in Italy, we said, we're France, we're the UK, we're the Netherlands, we don't have to care about it. Then it came to our countries. Then it said in the Netherlands, we said it's a problem of Brabant, the area where it first started. And we saw people that were totally neglecting the fact that you needed to do something. And this has to do with the fact that we humans are really bad when it comes to exponentially growing threats. At the beginning, it is really small, but it doubles every 2 days. That was the beginning of COVID. You take some measures, it doubles every 3 to 4 days, but the numbers are small and nobody really has the feeling it's important. And then comes the time when we suddenly see significant numbers and we realize it's really dangerous. And only then the measures have been taken. So what we see in our countries is in these areas where there was a little prevalence and the measures were intact, the number of patients in the hospitals and the ICUs were not overwhelmed. So I think we can really learn from that. And we have to be very careful when kind of easing the measures and going back to normal, that we don't get a second or a third wave of rebound if you do go too fast. I think all of us have to think about another challenge, which is the backlog of patients that we haven't been treating. So this is a big logistic problem. In Nijmegen, we were lucky because we had decided relatively early on that we keep a certain part of our hospital open for regular patients. So our backlog in our department is comparably low. It's about 10 times lower than in other departments. But also we see a big problem coming up. But I think that Strasbourg is probably one of the areas where you will have a lot of problems there. Is that true?
Yeah, with our ED activity for about a month was like 95% COVID, or maybe 97% COVID, and we didn't saw any other patient. So some of them go to private practice or like peripheral hospitals because they were really afraid to go to our hospital where was like the reference center for COVID. But I think most stayed home, and we are beginning to see like patients with late disease as mentioned earlier. So yeah, this will definitely be a problem.
Yeah, I think it is very interesting also what Dr. Bull said, that a lot of patients that usually would go to the doctor now stayed home. So we go back to seeing really full-blown presentations that we were not seeing. We see, for example, our intra-arterial thrombolysis for stroke service has completely collapsed, which basically means that a lot of people really suffered a stroke but were not treated. We see similar things for myocardial infarctions. So we will see some collateral damage, which will probably be bigger than we would have hoped for. I would like to close because we have spent already quite a bit of time. I would like to come to a very last point, what we heard from Dr. Bull, but also from Dr. Brink, but I'm pretty sure it's the same in Strasbourg. COVID was a big catastrophe for those affected. It was a big strain on our healthcare systems, but it also brought out a lot of good in the population, but also in our colleagues, and it actually fostered collaboration. It made things possible that otherwise would take years. And I think the catastrophe has the good side that it also is a big chance of reforming things that we need to reform, and we should really make sure that the chances that we have now are not left unmet, and that we actually use them in an optimum fashion so that our healthcare systems come out of this crisis much stronger than before. And with that, I would like to thank everybody for their contribution. I'm Mathias Prokop from Nijmegen, and I would like to thank Dr. Bull, Dr. Oana, and Dr. Brink. And with that, I wish you all a very nice day.